Well, the next speaker is Norman Briffa, who's on the valve clinical reference group, and will be telling us about the latest developments there. Norman.
All right, sorry. Thank you. I'd like to thank the organisers for asking me to speak on commissioning and heart valve surgery. Maybe not for the probably least sexy title of any talk ever presented in the Society annual meeting. Now, I was asked because I sit on the cardiac surgery CRG, as Clifford has said, but this is actually the full title. So I'm afraid I'm going to have to spend a bit of time just to explain what a CRG is and does and what we're able to achieve. And that means you're going to have to, I'm afraid, listen to a bit about the reorganisation of the English NHS, which occurred with the NHS Social Care Act of 2012. This cartoon was published by the King's Fund, which is, as you know, is a think tank in healthcare, and just shows you how incredibly complex the new NHS in England, not in Scotland, I have to say, is. At the top of the NHS in England is NHS England. It is previously known as NHS Commissioning Board, and it commissions primary healthcare services from CCGs or clinical commissioning groups, and it also directly commissions specialised care, and cardiac surgery is a specialised service. It's nationally accountable, and that's the budget, 11.8 billion, or 10% of the whole budget. So this just shows you, essentially, NHS England commissions from the CCGs. CCGs themselves commission secondary care from provider hospitals, but NHS England directly, through local area teams, directly commissions specialist services. Right in the middle, I'll come back to them, are clinical senates, and that's quite important. NHS England is divided into 4 regions, and they have 25 local area groups. But when it comes to commissioning, there are only 10. They're called local area commissioning hubs. And that's the map. Let's go back to the clinical senates. One of the main reasons for the reorganisation of the NHS was to directly involve clinicians in the planning of services and in the commissioning of services. And there is a clinical senate map, which is very similar to the last map, but not quite the same. Why it's not quite the same, I'm not so sure, but that's the NHS. Within specialised services, clinical senates are represented in these things called CRGs, and the CRG stands for Clinical Reference Centre. As it says, the CRG will be the key delivery mechanism for the development and assurance of specialised service contracts products for NHS England. And obviously we'll have membership from each senate area, because that's how clinicians are involved in the planning and commissioning of services. There are 5 program boards, program of care boards, and cardiac surgery on the left comes from the internal medicine one, then there's thoracic surgery, which obviously some of us are involved in. That's in the cancer and blood program board, and then congenital heart services in the women and children's program board. This is probably the most relevant slide that I'm going to present today, and this is all about the funding gap, because you don't go to any meeting involving the NHS without somebody showing us the funding gap. So by 2020, there's going to be a discrepancy between projected resources, projected costs of 15 to 20 billion pounds. So the cardiac surgery CLG will be the main point of contact with NHS England for anything to do with cardiac surgery, whether it's planning of services, whether it's planning QUIP projects, work streams, sequence targets, which are financial sweeteners for achieving quality targets, and for service specs for anybody who wants to do cardiac surgery for the health service. And it's work in progress. The CRG is chaired by Danny Keenan, who's a consultant at the Manchester Royal. And one of the first things he did was introduce 3 subdivisions. Initially there were 4. He included arrhythmias, or treatment of AF, but we decided to combine that with the heart valve disease. So we've got 3 main sessions, and I lead on the heart valve disease. And that's why I'm here. The specs for 2014 has already been published, and it's actually open for consultation at the moment. there's nothing controversial within that document, and there's nothing really specific as far as planning of cardiac heart valve surgery. But about 2 weeks ago, there was an event for the internal medicine program of care where interested parties, members of the CRG, were asked to place so-called A3 strategy plans. And 3 were placed. There was ischemic heart disease support for heart attack teams. There was development of a national network for the management of aortic valve dissection, and then aortic dissection, and from the heart valve point of view, developing networks and heart teams for optimal management of patients with heart valve disease. And I suppose it's development of heart valve centers of excellence. Now, I'll quickly go through the evidence base. We've seen all this. We know valve repair is superior to valve replacement in the management of patients with degenerative mitral valve regurgitation. We've also mentioned this several times, the paper by Gami, which looked at the effect of procedural volume, and he looked at over 13,000 operations for mitral valve insufficiency, and he showed that the more repairs that a hospital performed, you are less likely to die, and you are more likely rather to have your valve repaired rather than replaced. And then Steve Bolling looked at the effect of volumes of individual surgeons, and again he showed that the high volume surgeons were far more likely to repair a valve than to replace it. We've mentioned this, and the more recent paper, which is the 16 standards that were described by a group of clinicians, including Ben and Simon. And I'll just highlight a few. The volume thresholds, which is surgeons should be performing 25 or more repairs, and hospitals should be performing 50 or more repairs. And the outcomes is mortality should be less than 1%, and 5-year reoperation rate should be less than 5%. Now, Simon has explained, these are not quite backed up by data, but there we go. This project has been started, actually, in June 2011, before the NHS was reorganised. NHS London started the so-called London Cardiovascular Project. And they looked at 3 things. One was management of patients with non-STEMIs who needed urgent CABG, management of patients with aortic dissection, and also management of patients with mitral valve regurgitation. They set up these standards, and essentially, standard 1 is that there should be MDTs or heart teams. The second standard was who should be in the heart team, so a surgeon, a cardiologist, and imaging specialists. The third, there should be an increase in repair rate in the area covered. Fourth standard was the volume standard, so 25 operations, i.e. mitral valve repairs per surgeon, and 50 per team or per unit. And also that there should be robust audit processes to monitor clinical outcomes, i.e. survival and reoperation rates at 1 year. And the document ended with an aspirational hope that by September 2014, the repair rate should be approaching 90% in London. I haven't a clue whether that aspiration has been reached or not. So the plan, really, of the CRG, this is work in progress, is to replicate what the London Cardiovascular Project did on a national scale within England. I suspect most units will achieve the numbers, or maybe we'll listen to what Simon said, and maybe we shouldn't be so rigid about the volume thresholds. Certainly, there needs to be an increase in the number of formal MDT teams. I think some surgeons will have to be invited to withdraw from elective mitral surgery. And there are obviously, I think, implications for other treatments, other management options, therapeutic options for the management of mitral valve disease. MitraClip, which until now wasn't commissioned in the health service, I think some limited commissioning is going to start fairly soon. So, it will be one of the therapeutic options for the mitral team to consider. As I said, work in progress. Getting to where we are now, to getting to where we want to be for the whole of England can be, as we know, quite tortuous and difficult within the NHS. You can see what happened to congenital heart surgery. But hopefully at the end, we'll end up with better management for patients with mitral regurgitation. Thank you.